So why does a familiar task suddenly feel different? You're halfway through a familiar task when the next step suddenly disappears. You lose the thread of a conversation, search for an ordinary word, or read the same sentence 3 times. After 60, it's easy for one frightening thought to follow. Is this dementia? Sometimes cognitive changes do come from conditions other than dementia. Some may be treatable or improvable, but finding one possible contributor does not rule out dementia, and more than one condition can exist at the same time. So this is not a test that tells you which condition you have. These 7 groups are a practical way to understand what may deserve attention. The most useful starting question is not, which one is mine? It is, did this change happen suddenly, or did it develop gradually? But what does brain fog actually mean? Brain fog is not a medical diagnosis. It is an informal description people use for reduced concentration, slower thinking, forgetfulness, or difficulty finding words. Dementia means something more specific. The National Institute on Aging describes it as a loss of cognitive functioning, thinking, remembering, and reasoning that becomes severe enough to interfere with daily life. That difference matters. Occasionally taking longer to recall a name is not the same as repeatedly getting lost, missing essential medicines, or becoming unable to manage familiar bills. Dementia is not a normal part of aging. At the same time, a new decline in everyday function should not be dismissed as just getting older. The phrase brain fog describes an experience. It does not explain the cause. Timing gives us the first important clue. So what could explain a sudden change? If confusion begins over hours or a few days, or alertness changes sharply during the day, this is different from a slowly developing memory concern. Doctors call this acute change delirium. Delirium affects attention and awareness. It can look agitated and obvious, but not always. Someone may instead become unusually sleepy, withdrawn, unable to follow a conversation, or noticeably less aware of what is happening around them. NIH. Medline Plus and the National Health Service list several possible triggers. These include acute illness, infection, dehydration, electrolyte imbalance, medication effects, hospitalization, and surgery. Infections such as a urinary tract infection, pneumonia, or influenza are possible triggers. But confusion alone does not prove any one infection. Sudden confusion needs urgent medical assessment. The same is true when confusion comes with weakness, speech trouble, fainting, fever, severe headache, chest pain, breathing difficulty, or an inability to stay awake. Do not wait for a routine appointment. This video cannot identify an individual cause or replace urgent medical assessment. It can only help you recognize which observations matter. Once an acute problem has been ruled out, a persistent or more gradual change raises a different question. What changed shortly before the fog appeared? The answer may be sitting in more than one medicine bottle. Certain medicines can contribute to forgetfulness, sedation, reduced attention, or confusion. The chance of an interaction also grows when prescriptions are combined with over-the-counter products, sleep aids, or supplements. This is where the term polypharmacy becomes useful. It refers to taking multiple medicines, which can make side effects and interactions harder to recognize. The problem is not simply the number of pills. It is how the full combination affects one person. Some medicines have anticholinergic effects. When several of those effects accumulate, clinicians may call it anticholinergic burden. Other products can add to sedation. Either pattern may matter when thinking becomes slower after a new prescription, a dose change, or an added nighttime product. The safe response is not to blame one medicine or stop it alone. Write down every prescription, over-the-counter medicine, sleep aid, and supplement. Then ask a physician or pharmacist whether timing, dose, duplication, interaction, anticholinergic burden, or sedation could be contributing. But what if nothing in the medicine list recently changed? Look for a pattern that repeats every morning. Could poor sleep be the missing piece? Sleep is not empty time for the brain. Broken or insufficient sleep can affect attention, learning, reaction time, problem solving, and the formation of new memories, a process called memory consolidation. That can make yesterday's conversation feel harder to retrieve, even when the problem began during the night. One condition worth evaluating is obstructive sleep apnea. A person may believe they slept all night, yet still notice clues such as loud snoring, witnessed breathing pauses, gasping, morning headaches, and marked daytime sleepiness. Those clues do not diagnose sleep apnea. They tell you what to mention during an evaluation. Treating a sleep disorder may improve sleep-related cognitive symptoms, but it cannot be promised to reverse every memory complaint or prevent Alzheimer's disease. Sleep can also overlap with the next contributor. A person who is exhausted may feel low, anxious, or mentally slowed. Sometimes the emotional strain came first. Could the mind itself be carrying the fog? When it's carrying persistent worry, depression, anxiety, or prolonged stress, concentration can narrow. Thoughts may move more slowly. Details can be harder to hold long enough to use them. These depression-related cognitive symptoms are real. They are not laziness, lack of effort, or something a person should simply push through. Anxiety disorders can also interfere with concentration, especially when attention is repeatedly pulled toward worry. But mood must not become a convenient explanation for every cognitive change. Depression and dementia can coexist. If someone is losing the ability to manage daily tasks, the concern should not be dismissed as just stress or just depression. Mood symptoms deserve care, and cognitive changes still deserve proper assessment. Medication, sleep, and mood can leave recognizable clues in daily life. Other contributors may not. You cannot reliably feel whether a vitamin level or thyroid hormone is abnormal. That is where medical history, examination, and selected tests become more useful than guesswork. Could a simple vitamin be behind it? Vitamin B12 supports the nervous system. A deficiency may contribute to confusion, concentration problems, or short-term memory loss. After 60, the issue is not always how much vitamin B12 a person eats. Absorption can be affected by conditions such as pernicious anemia, gastrointestinal disease, or surgery, and certain medicines. In other words, a seemingly adequate diet does not always settle the question. Long-standing vitamin B12 deficiency can cause neurologic damage, so persistent symptoms deserve evaluation. But symptoms alone cannot diagnose the deficiency. A clinician may use a blood test and, when needed, additional testing to interpret the result in context. Taking a high-dose supplement as a home experiment does not prove that B12 caused the problem. Treatment depends on why the deficiency exists, and complete recovery cannot be guaranteed in every case. The same principle applies to another internal regulator that can affect both energy and thinking. Could the thyroid be quietly involved? An underactive thyroid, called hypothyroidism, can contribute to forgetfulness and slowed thinking. An overactive thyroid, called hyperthyroidism, can also resemble a mood or cognitive problem. After 60, hyperthyroidism may not always look like the classic picture people expect. Reduced appetite or social withdrawal can sometimes be part of the presentation, which may be mistaken for depression or dementia. Clinicians often begin the thyroid investigation with TSH, and may also use free thyroxine, known as free T4. These are not do-it-yourself answers. They are clinician-interpreted tests that must be considered alongside symptoms, medical history, and other findings. An abnormal thyroid result does not automatically explain every cognitive complaint. Correcting thyroid dysfunction also cannot guarantee that every memory problem will disappear. It may be one contributor inside a larger picture. And what about blood sugar? People often use the word sugar as a catch-all explanation for tiredness or brain fog. That is too vague to be useful. Hypoglycemia means blood glucose has fallen too low. The Centers for Disease Control and Prevention defines a level below 70 milligrams per deciliter as low. Below 54 is considered severe and may require help from another person. Low blood glucose can cause confusion, dizziness, weakness, visual difficulty, unusual behavior, seizures, or loss of consciousness. The risk is especially relevant for people with diabetes mellitus who use insulin or other glucose-lowering medicines. Acute confusion in a person with diabetes may be an emergency. Severe high glucose crises can also alter mental status. Follow the individualized plan provided by the healthcare team and seek urgent help for severe symptoms or when a person cannot swallow safely. Do not improvise a medication change from information in a video. This does not mean that every persistent cognitive complaint is caused by glucose. It means that a sudden change in someone using glucose-lowering treatment deserves a specific, medically informed response. But what if more than one explanation fits? At this point, one cause may seem to fit perfectly. Perhaps a sleep aid was added. Perhaps snoring has become louder. Perhaps stress has been relentless. That recognition can be useful, but it is not a diagnosis. Several contributors can exist together. Poor sleep may sit beside depression. Medication effects, dehydration, or illness may overlap. Vitamin B12 deficiency or thyroid dysfunction may coexist with a neurologic condition. Some contributors are treatable or improvable. That is a reason for thoughtful evaluation, not a promise that all brain fog is reversible. It is also why finding a plausible contributor does not rule out mild cognitive impairment, known as MCI, dementia, Alzheimer's disease, or another neurologic condition. The impact on daily function matters. Pay attention when a person increasingly struggles with bills, medication management, navigation, conversations, cooking, or personal care. Those changes call for formal cognitive and medical assessment. The goal is not to attach the most frightening label. It is to avoid missing either a treatable contributor or a condition that needs ongoing support. So what should you actually bring to the doctor? You do not need to arrive at an appointment with the name of a disease. A short timeline may be far more helpful. First, when did the change begin? Second, did it appear suddenly or develop gradually? Third, does it stay fairly consistent, or does attention and alertness fluctuate? Fourth, what changed beforehand? Include medicines, illness, sleep, mood, appetite, hydration, alcohol use, a fall, or a head injury. Fifth, which daily tasks have become harder? Be specific about bills, appointments, medicines, directions, cooking, conversations, or personal care. Bring a complete list of prescriptions, over-the-counter products, sleep aids, and supplement. If possible, note when each recent change occurred. That turns "I feel foggy" into information a healthcare professional can investigate. Your own clinician knows your conditions, medicines, and risk factors, so do not diagnose the cause or change treatment alone. The final decision is simple, even when the cause is not. Sudden confusion, a sharp change over hours or days, or any acute red flag requires urgent medical help. New, persistent, worsening, or function-limiting concerns deserve a scheduled professional evaluation. Brain fog is a description, not a verdict. You may not know the diagnosis yet, but you can notice the timing, record what changed, and take the next step safely. Stay well, and I see you in the next one.